the urinary system comprising of the kidneys. You can see that the location of the kidneys, especially, it's right below the ribs. Like when people have kidney stones or issues with kidney infections, if the infection reaches up to the kidneys, then they complain about pain around this region, the flank region of the backside. So because kidneys are quite high up, we normally think like kidneys are somewhere here, but it is not so. It's quite high, just below the ribs. So this is from a location perspective. And the kidneys, they help to get rid of the waste, and it forms the urine, which travels through these two tubes called ureters. Okay, and then through the ureter, the urine comes and gets accumulated in the urinary bladder, which is like a sac-like structure. And then from the bladder, it is expelled out. So basically, we are going to study about the microscopic structure, the anatomy of the kidneys, and it has a very fine, delicate structure called nephron, which is the structural and functional unit of kidneys. So we're going to study about the nephron, the tissues involved in it, the filtration mechanism in it, because when we are talking about getting rid of the waste, that means it has to filter out the waste, retain the good substances, and get rid of the bad substances. So that's why filtration is so very important. So kidneys, they produce urine, ureter, as I showed you, these two tubes, they transport the urine towards the bladder. The bladder will store the urine temporarily, and then it will eliminate through the urethra. And in case of males, as you will read in the reproductive system, the urethra also helps to get rid of the semen. So introduction, the paired kidneys, they have excretory function, they produce urine, and it's a fluid that contains water, ions, soluble compounds, and it flows through the ureters. Okay, so one point over here, why I have circled this over here is because in the exam, students typically get confused between ureter and urethra. So I want to show you this very clearly. This is the urethra, U-R-E-T-H-R-A. And these two tubes are the ureters. Students lose points over here because the question will ask which one is connected between the kidneys and the bladder, and they write urethra. No, it is ureter. Okay, so mark the spelling between ureter and urethra and their location and their functions. Okay, so it's the ureters, and then the urine collects in the bladder, which is a temporary urine storage bag or a sac-like structure, and the urethra conducts or expels the urine out to the exterior. The process of formation of urination, okay, the whole process, and the process of expelling it out, especially to expel it out, the expulsion or getting rid of the urine is called micturition. Look at the spelling, micturition. Functions, so is it just the urine expulsion? No, the kidneys have very, very important functions, and people especially who have like diabetes for a prolonged period of time, say 20 years or 30 years of diabetes, ultimately they end up with some form of kidney disease or CKD, chronic kidney disease. And then this chronic kidney disease ultimately leads to heart failure. That means kidneys have something to do with sugar, and they have something to do with cardiovascular function. Right there in the center is kidney, and it's very, very important. And once the kidneys are damaged, it just proceeds and becomes worse and worse. So one of the functions is hormetic regulation. So kidneys play a very important role in balancing the volume and pressure. So these two things you have to remember: blood volume, blood pressure, by adjusting the volume of water lost in the urine. Now, as you have read blood, you know that a big chunk or a big component of our blood is water, fluid. So if a person loses fluid, they have a tendency to be dehydrated. Okay, so blood volume loss is going to be very, very crucial for a person with respect to heart functioning. And you know, cardiac output and all the EDV and ESV and all that we have studied so far, the role of sympathetic nervous system. So blood volume and blood pressure are very, very important factors. And kidneys regulate that balance between fluid retained and fluid lost. That balance is done by kidneys. If a person is losing too much of fluid, too much of urination, it would offset or cause a disbalance of the fluid volume in the body and therefore affect the pressure as well. They regulate the plasma concentration of sodium, potassium, chloride. So many ions are also controlled by kidneys. Then they help in stabilizing the blood pH. So we will deal with two ions like hydrogen ions and bicarbonate ions. So remove the hydrogen ions, retain the bicarbonate ions, and hence stabilize the blood pH. So if the blood is becoming too acidic, that means H plus is increasing. So kidneys have to devise a mechanism to flush out or get rid of H plus. Retain the bicarbonate ions because we are going to use the bicarbonate ions as a buffer to neutralize the pH of the blood. So that's how kidneys not only get rid of the waste substances, they also help in retaining of substances, good substances, getting rid of some ions that could offset the balance or homeostasis consistency in the body. They conserve valuable nutrients that we already know. So if things are getting lost in the urine, like glucose or proteins, then you'll find that the person is beginning to show signs of disease because there is loss of albumin in the urine, which should not be. And they assist the liver in detoxifying poisons. Liver is a great center, a chemical factory, and a detoxifying center where they get rid of drugs and alcohol and chemicals and all kinds of bad substances. They are detoxified in the liver and dumped into the kidneys to be expelled out. So functions of the kidney, so urine formation, eliminating the waste. And it also helps in removal of potassium ions, nitrogenous waste. So when we talk about waste, there are three major wastes that you need to understand. Number one is urea, and it is an end product of protein metabolism. So if you take protein, it breaks down into amino acids, okay? And then deamination process is going to produce ammonia. Ammonia is highly toxic, so quickly it converts into urea. Urea is less toxic. And then from the liver, urea is sent to the kidneys and flushed out in the urine. Now, if a person is showing high levels of urea in the blood, that means what does it indicate? It indicates that the kidneys are performing poorly. They're not functioning as well as they should. Then uric acid, where does that come from? It comes from DNA and RNA metabolism. Creatinine, it comes from muscle waste. Okay, so creatinine, uric acid, and urea. These three are very, very important to understand how the kidneys are functioning. They don't have to be completely removed from the body, but they should be removed from the body because they are toxic substances. Accumulation of these in the blood will lead to it will show signs of complete failure of the kidneys. Now, creatinine, its level is very subtle, like 1.2 or 1.3 or even 1.4 can make a lot of difference in a person's body. So these parameters need to be controlled very strongly. And every person after the age of 30 should go for their lab test at least once a year and check their kidney functionalities because of the diet and the environment that we are exposed to these days. Nobody should take a chance. Just go and get your kidney functionality test done to check about creatinine, because some people go to gym and they take these protein shakes and they take more protein diet, and sometimes the body is not prepared for it or doesn't metabolize it well enough. pH control. Urine usually has an acidic pH, then erythropoietin. So kidney secretes the erythropoietin hormone, and I think you have already read about it, and it helps in stimulating RBC formation. Okay, then activation of vitamin D. So we get our source of vitamin D from the sunlight. It's called the sunshine hormone, or we get it through the diet. And then the vitamin D, it is calcidiol in the liver converted into calcitriol in the kidneys, and it helps in the calcium and phosphorus metabolism. So kidneys have a role to play in this because they convert calcidiol into calcitriol. They work on vitamin D so that it can act on calcium metabolism. So kidneys have a role to play in RBC. They have a role to play in calcium metabolism as well. Blood pressure regulation, this is the most important. People who suffer from high blood pressure, hypertension for a prolonged period of time, they usually end up with some kind of kidney ailment because the blood pressure regulation is done by kidneys. I'll explain to you how it is done by renin through the RAS mechanism, and for a short term, kidney will provide assistance by increasing the blood pressure or managing the blood pressure. But if it is a chronic thing, it keeps on happening for a prolonged period of time, eventually it will show its effect. So this is the location. Anatomically, they are retroperitoneal. Remember, this is a question for you. What is the position? Is it retroperitoneal? Yes, it is behind the peritoneum. And the right kidney is lower than the left due to the large liver to accommodate for the liver. Now, looking at it structurally, 3 concentric layers of connective tissue are there. Number 1, there's a fibrous capsule outside made out of collagen fibers. Then there is a cushion of fat made out of adipose tissue. And then lastly, there is a renal fascia that is a fibrous layer. So remember the location of these, deep to superficial. So deep, this is the kidney. Deep to superficial, that means number 1 would be the fibrous capsule, and then the perinephric fat, and then the renal fascia. Yeah, I'll show you a picture of it. So this is how it looks. When you do the dissection, you can see how they have removed the outer layer, the 3 layers of the connective tissue. And they've shown the structure of the kidneys, and you can get an idea how big it is. And the renal fat is actually for protection, the adipose fat. External anatomy of the kidneys. Each one weighs 150 grams. It was way big. Okay, yeah. Have you already done the dissection of what do you do the dissection on? Cat dissection? Okay. Yes, cat. Okay. So I also teach at another college, and there we have to do the cat dissection. And when I studied in India, and we do rat dissection over there, white rat dissection. So when I came to US, and my professor, my department dean, she said, you have to do cat dissection. And I said, okay, maybe cute cats, very small and cute cats, okay, it would be difficult to dissect them. Like I have emotional like feelings for the cat. But when they brought the cat, it was like way big. It was huge, like a big wild cat. And it looked horrible, actually. And it came from Virginia to Indiana, and they were frozen and so big. I remember doing the cat dissection, and I was like, I don't really like it. Anyway, and then one time, one of my students screamed and yelled because they opened the cat, and it was pregnant, having a baby cat inside it. So the whole class was, very amused by it. Yeah. So coming back over here, so here's the kidney, and this point is the hilum. And why it is called hilum? Because it is the point of entry for the renal artery and the renal nerve and the renal vein. So entry of the artery, exit of the vein, and the nerves also entering. So that junctional point is the renal hilum. So the macroscopic structure of the kidney, how it looks, is the renal cortex, like as you can see during the dissection. So if this is the kidney, the top hat of the top portion, that's the cortex, it's superficial. Then inside part, that's the medulla. This inside part is the medulla. So cortex and medulla. Then you'll find that the medulla is divided into cone-shaped pyramids. Okay, there's divided into cone-shaped pyramids like this, the medulla. These are pyramids, and you can call that as a lobe, like a section would be a lobe. Okay, a lobe. And the tip of the pyramid, if you look at the tip of each pyramid, this tip would be called as the papilla. The papilla, that's the tip of the pyramid. So again, okay, like this, let me show you. Cortex, the hat part, the top part is cortex. Then the remaining part, all the remaining part, this is all medulla. Now in the medulla, you have pyramids like this, okay? This pyramids, and the tip part of each pyramid, this tip part of each pyramid would be the papilla. And they all lead, they'll direct the urine towards the funnel-shaped tube or the renal pelvis. They will direct it towards the funnel-shaped renal pelvis over here, this diagram. So over here you see this part right here, this is the cortex. The rest of the part is the medulla. Now the medulla is divided into these kind of pyramids, okay, renal pyramids. And the tip part of the renal pyramid, we are going to call it as papilla. This tip part is the papilla, like it has shown you over here, the papilla of the pyramid. Okay, then next slide. Minor calyx that collects urine from each pyramid. So each pyramid is going to get connected to a minor calyx, and the major calyx that collects urine from several minor calyces, and they all flow into the renal pelvis. So if you have so many pyramids over here, this is a minor calyx, minor calyx, minor calyx, 1, 2, 3 minor calyxes will all get into a major calyx. This is a major calyx, okay? And then they all flow into the renal pelvis. So again, this is the structure of the kidney. Outer one is cortex, inner one is medulla. In the medulla, we are having pyramids. The tip of the pyramid is the papilla. From each papilla, you have minor calyx, and couple of minor calyxes, they will join to form major calyx, and that will lead into the renal pelvis. Then hilum, as I told you, it is the entry and exit for artery, vein, nerves. So this is how it looks, okay? So any questions? These columns that you see, these columns are cortical columns in between the pyramid. This is falling in between the pyramids. Okay, so whatever I explained about pyramid, cortex, minor calyx, pelvis, renal sinus. So the pelvis will lead into the renal sinus, and then it is connected to the ureter, and it will drain the kidney. Any questions? Or do you want me to draw this again and explain to you the structure? Okay. Okay. Now let's look at the blood supply, how the blood enters the kidney. This graph, this sequential concept map is going to give you clear picture of the direction of blood. Aorta means it is coming from the heart, okay? So from the lungs, left atrium, right atrium, okay, and then comes through the, then it comes through the dorsal aorta. I'm talking about the dorsal aorta. This one, the dorsal aorta, from the heart comes to the renal artery, segmental artery, interlobar artery, arcuate artery. Arcuate means it's like an arc. Cortical radiate artery, afferent arteriole goes into the main junction point glomerulus, and then it returns through the efferent. Look over here, this is afferent, this is efferent. When it comes, it is afferent. When it goes away, it is efferent. Don't get confused between the two. Then from the efferent arteriole, it goes to the peritubular capillaries. It is and, I will rather call it or. Instead of and, I would write over here or vasa recta. Why or? I'll tell you. So here is the kidney. Okay. I told you that the main component or the main part that does the filtration, that does all the functions of the kidneys, the structural and functional unit, that's the nephron. That's the nephron. Okay. Now we have this kidney outer cortex. This is the outer cortex, as I explained to you. And the inner one is the inner medulla. This is the medulla, the outer cortex, and inner medulla. Structurally, these are two parts. Okay, I have a shirt and I have a pant. So the cortex is the shirt and medulla is the pant. However, the microscopic structures that I'm going to talk about are the nephrons. There are millions of nephrons in the kidneys. There are nephrons here and there are nephrons here. And nephrons are the ones which produce the urine. Nephrons do the filtration. Nephrons do the reabsorption. Nephrons do the secretion. Nephrons do all the work of the kidneys. But when the nephrons are doing the work in the cortex, remember, they involve peritubular capillaries. So peritubular capillaries would be present if it is location-wise nephrons of the cortex. But if it is nephrons of the medulla, then it will not involve these guys. It will involve vasa recta. Okay, so that means from the efferent arteriole, when the blood goes, either it will go through the peritubular capillaries like this, or it will go through the vasa recta. It is not and, it is or. Either through the peritubular capillaries or through the vasa recta. When will it go through the peritubular capillaries? It will go through the peritubular capillaries if the nephron is present in the shirt. If the nephron is present in the shirt, that means the cortex, then it will go through the peritubular capillaries. But if the nephron is in the pant region, I'm giving an example. If it's in the pant region, that means the medulla, then the blood will go through the vasa recta. So be very clear about it. After it moves through the either peritubular or vasa recta, then it will join the cortical radiate vein, go through the arcuate vein, go through the interlobar vein, renal vein, inferior vena cava, comes back to the heart. So that is why heart is connected to the kidneys. Okay, it provides the blood supply. It removes when the blood comes out, it goes back to the heart. So it's easy to remember the names. You just have to flip the term artery with vein. All the red is artery, all the blue is vein. Only one difference. Did you notice it? We have a segmental artery over here, but we don't have a segmental vein over here. So keep that in mind. There is no segmental vein on the other side. That's all. So this is how blood supply comes to the kidneys and returns from the kidneys back into the body. Now, here I want to tell you something. The blood that is coming to the kidneys, especially the glomerulus, the site of filtration, this is our junctional point. The blood that is coming, maybe it is bringing A, B, C, D, and E. It's bringing A, B, C, D, and E. out of this, we intend to remove B and D, but we will take back A, C, and E. Okay, we will take back A, C, and E. We intend to remove B and D. For us, A, C, and E are good substances. They just came in the blood, but they are good substances. For us, B and D are bad and bad. This is good, this is good, and this is good. If we remove everything, we are dead. So we intend to return the A, C, and E back into the body system. But we intend to get rid of B and D via urine. Okay? So when the blood comes and the filtration happens, I want to get this concept very clear to you. If you understand this much, the rest of the stuff becomes easy for you. So when the blood comes, we are bringing A, B, C, D, and E. Okay? It comes to the glomerulus. Then, after the filtration happens over here, we are forming urine. And in the urine, we are having B and D, okay, after the filtration. A, C, and E are supposed to go back alone without B and D. If this process happens, then you can know that kidney did its job. That means filtration was successful. However, sometimes, or not sometimes, always, some amount of A and C may show up over here in very minute amounts. It might come out. We need to put it back. So again, this minor amount that somehow came and was not filtered properly will join over here and go back. And the intention is to give it back to the body. Okay, it will return back to the body. So this is the whole mechanism, how it operates. Good things come with bad things. We remove the bad things, we take the good things and return it back into the system. Is that clear? Okay. Okay, thank you. So now, whatever I explained to you, the arteries, which one leads to what and everything, the branches of the arteries, that all is explained in this slide. Blood supply, innervation of the kidneys, the cortical radiate delivers to the arcuate, they empty into the interlobar veins, then it goes back to the renal vein. Just everything is explained. So I'm not going to repeat this. It's just a summary of whatever I explained. Blood and nerve supply, renal arteries that deliver around 1200 milliliters of cardiac output to the kidneys each minute. So it works round the clock. And arterial flow into and venous flow out follows similar path. I showed you the path by way of the arrows. And nerve supply is by sympathetic fibers from the renal plexus. So whatever we discussed, it is just shown over here, the arrangement of the artery, how it comes. Look over here, renal artery, how it, this is the hilum. This is the hilum, the main point where it is the entry and exit of the renal artery, the renal vein, and the renal nerve. So now renal artery will enter, and then how it is going to branch out into segmental arteries. Then between the lobes, it is interlobar artery. Then wherever it forms an arc like this, it is the arcuate artery. And then in the cortical cortex, this is the cortex, right? In the cortical region, it is cortical radiate artery. Right here, you want to see where are the nephrons. The nephrons are here. The nephrons are here, okay? These are the nephrons in the cortex, and these are the nephrons in the medulla. So each of these arteries are connected to the glomerulus. Glomerulus is the junctional point, Okay, and then the blue ones are the veins. Again, cortical radiate vein, arcuate vein, interlobar vein, renal vein, and then out. This is in, this is out, in and out. Okay, no segmental vein. Keep that in mind. Okay, so now urine is formed in the kidneys, and then it has to move down through the ureters into the bladder, and the ureters are also retroperitoneal in position. That means behind the peritoneum, and they enter the bladder. There are no sphincters. As the bladder pressure increases, distal ends of the ureters close, preventing the backward flow of urine. So kidneys, ureters coming down into the bladder. Okay, there are no sphincters over here. They just enter into the bladder from the posterior side or posterior surface, like slits, There are cut, like if this is the bladder, there are slits. Okay, and one tube enters, the other tube enters. No sphincters, just slits, and then it enters and it prevents the backward flow of urine. This is histology, you have to remember it. What are the layers of the wall of the ureter? It has transitional epithelium. Transitional, why transitional? Because transitional epithelium always provides some space for stretching. And then a lamina propria, no submucosa. What is the muscular layer? It is longitudinal muscle and circular muscle. What it does, it helps in peristalsis, because we know that we need some amount of peristalsis so that the urine can flow down. Now, if people have stones, then it's another story, because stones are very painful when they drop down through the crystals, when they drop down through the ureters. Adventitia, that is connective tissue. Okay, so ureter, the description of the ureter consisting of the three layers, the transitional epithelium, the middle layer with long circular bands, same thing, just explained over here. So this is a section and it shows you the transitional epithelium. Okay, if you look under the microscope, this is what you're going to see. The muscle layer, muscularis, longitudinal and circular, and finally the connective tissue, adventitia. Bladder, it is also retroperitoneal, behind the peritoneum. And it will have definitely transitional epithelium, because when we drink a lot of water, the bladder is full and it's going to expand. So if you have anything that is expanding, you need transitional epithelium. And it has a thick detrusor muscle, 3 layers of smooth muscle. Detrusor means to thrust down, because you know, if the person has to pee, then it has to contract and squeeze the bladder so that the urine can be expelled out. So detrusor muscle means to thrust down, and it has 3 layers of smooth muscle. And it has the shape of a trigone. It's a smooth triangular area outlined by openings of the ureter and urethra. And infections tend to persist in this region. So if you look at the bladder, it's kind of a triangular structure, and you have the ureters entering, and this is the urethra. These two are the ureters, this is the urethra, and together they form kind of a triangle, inverted triangle, and that's why it's called as trigone. Tri means 3, because it has 3 openings, 2 ureters and 1 urethra, and this is the part which has more susceptible to urinary tract infection. It gets inflamed and it can't hold the urine. So if a person has urinary tract infection, they run to the toilet frequently, because the bladder is so inflamed and red and it's swollen up, and it loses its capacity to hold the urine. So there is urine leakage, or the person has to just run to the restroom frequently. That's the first sign that there is some kind of an infection going on. And most often the infection is because of Klebsiella bacteria. That is a good bacteria. It remains in our alimentary canal. It remains in our digestive tract. It helps in digestion. It's a good bacteria, but it tends to become naughty and bad and wicked if you allow it to. It's an interesting bacteria. if you study microbiology, you'll learn more about Klebsiella. So sometimes when you don't go to the restroom often, you tend to hold the urine. Anytime you hold urine, especially ladies, because they have a short urethra, they're more prone to this infection. So if you hold the urine, even good bacteria will become wicked because they're going to multiply more. You need to flush it out, not hold urine in the urinary bladder. And then what happens from the digestive tract, Klebsiella moves. If people are not cleaning well also, it moves from the digestive tract to the urinary bladder region and then flare up of urinary tract infection. Okay, so that's a bit of pathophysiology for you. So if you look at the diagram over here of the urethra, outer covering is the peritoneum, then look at the ureters. Look at the ureters, how they're coming from the posterior side, from the behind, and then entering. There is no sphincter here, just slit, and it prevents the backward flow. Then we're looking at rugae. These are the folds called rugae that allows for expansion, transitional epithelium. And we are looking at these ureteric orifices. Now these two tubes are coming from behind. Look at the slit where they are opening, oblique slits like this. Okay, we have an internal urethral sphincter right here. This is a sphincter that's involuntary. We do not have control over it. Then we have some external sphincter that is voluntary. We have control over it. We don't have control over here. We have control over there. So when you don't have control, it is involuntary. It's pretty much like the anal one. When we were reading about digestive system, there was an internal one and there was an external one. The internal was involuntary and the external was voluntary. Same thing over here. You feel like going to the restroom when this one is activated. Then finally, here's the urethra. Look at the spelling. And then the external urethral orifice. Orifice means opening, and the urine is flushed out. Okay, so whatever I explained, same thing, the trigone, the internal sphincter, which is involuntary, the layers, the wall layers, longinal muscle, circular, detrusor. Detrus means to push the urine out. Detrusor contracts, so it compresses the bladder, expels the urine into the urethra. So looking at the urethra, the male urethra, a little bit you have to understand the male is a little bit different because it is also the passage for the flow of semen. So a bit of reproductive system. When we go to reproductive, you'll come back over here to the urethra. So in case of male, it's different from female because of it's a joint function, dual function in reproduction and the urinary system. So the urethra is divided into prostatic urethra, membranous urethra, and spongy urethra. It's different than the female. And in female, the urethra is very short. It extends just from the bladder to the vestibule. Okay, and external one is under voluntary control. The urethral sphincter, it acts like a valve. The urethral lining, it consists of stratified epithelium that varies from the transitional epithelium at the neck. So remember this, that there is transitional epithelium at the neck of the bladder. Okay, but the urethral lining has stratified epithelium, and it changes like the whole structure, it kind of changes from point to point. When it comes to the urethra, it gradually changes from transitional to the stratified. So here is transitional because it has to store the urine and it has to swell up, expand. So that's why it is transitional. But when you come down to the urethra, it changes into stratified epithelium. Why stratified? I've told you stratified means multi-layer. Why multi-layer? Because it's going to tolerate the acid content of the urine. The acid, the waste which is going to come, it might erode or cause scars in the walls. That is why it needs thick layer. That's why it's not squamous. Squamous is single layer, flat. This is stratified, multi-layered. It can resist the acidity of the urine. Okay, so that's why it's stratified, and that's it. So now urethra is muscular tube and transitional near the bladder because the bladder has to hold the urine and expand. So we have transitional. Then stratified, when you move anything towards external, it is always stratified. Whether it's like, even if it is squamous, it will be stratified, not simple squamous. It will be stratified, multi-layered, because it is connected to the external surface, like the mouth or the anus or the urethra. These are connected wherever there's external orifice, external opening. So it has to be multi-layered. That's why stratified. Female urethra is short, whereas in male it is prostatic, membranous, and spongy urethra. Now with this we finish the macroscopic structure of the kidney, the things that we can see. Now we will come to the things that we cannot see without a microscope, and that is nephron. That is the structural and functional unit. That is the main work of kidneys, is to make use of nephrons to produce urine and get rid of the waste. So what are the two main parts? The number one part is a renal corpuscle. Okay, so the kidneys are called renal organs, and the renal corpuscle, that's the most important one. And then the second part is the renal tubule. Both are important, both have some important job to do. So how does it look? So if you're talking about a nephron, it's going to look like this, like a tuft of capillaries, a tuft of coiled, blind-ended capillaries. That is the glomerulus. Okay, that's the glomerulus. Okay, now it's present in a capsule. It's present in a capsule. It's present in a capsule, and we are going to call the capsule as Bowman's capsule. Bowman's capsule. Okay, so that is together the renal corpuscle. So renal corpuscle equals to glomerulus plus Bowman's capsule. This inside tuft of capillaries is glomerulus. The outside cup-like structure is the Bowman's capsule. Together we are going to call it renal corpuscle. Then it's connected to the renal tubule. So what's the renal tubule now? The renal tubule will look something like this: the PCT, then the loop of Henle, the DCT, and then we'll end over here, the DCT. So proximal convoluted tubule, PCT, loop of Henle. This is the loop of Henle. It looks like a loop. It has a thin descending one. It has a thick ascending one. This is just right, the U structure. That's just the loop over here. So thin descending, coming down, thick ascending. So this is thin. This is quite thick. Okay, and then the distal convoluted. Convoluted means it's coiled. The word convoluted means it is coiled up. So proximal convoluted, it doesn't look like this straight. It looks like coiled. Okay, like this, coiled. So proximal means nearer. It is near. Proximal means near. So near to the glomerulus. So proximal convoluted tubule. Loop of Henle. The whole thing is called loop of Henle. Down is descending. Up is ascending, and then this distal convoluted. Distal means far, further, far. So distal convoluted tubule. So this one plus this one together is the nephron. We are going to look at what happens over here and what happens in the tubule. Okay, so here, so typically this is how everything looks. So here's the kidney, outer cortex, inner medulla, the pelvis, whatever, and the ureter, and it goes down to the bladder, and then urine out. This is macroscopic. This is what you can see with your naked eyes. You take a small part of it and pull out the nephron. You take a small part of the kidney and magnify it over here to look into the microscopic structure of nephron, which you cannot see with the naked eye. You need a microscope for it. And then you can look over here. It is consisting of the renal corpuscle, this big guy, and the entire thing, the renal tubule. The whole stuff is the renal tubule. Okay, so when we say tubular fluid, it means the fluid which is passing through these tubes. Okay, when we say the term tubular fluid, in your question, you might see sodium is getting reabsorbed into the tubular fluid. It means the fluid that is traveling in these pipes or tube. Now, what are these pipes? What are these pipes? These pipes are, we begin with PCT, proximal convoluted tubule. We move down, this is thin. Excuse me, this is thin. Descending is thin, ascending is thick, okay? And here's the loop. And then this part is coiled. This is the distal convoluted tubule. So PCT, descending, ascending, DCT. The whole stuff is renal tubule. This guy is corpuscle, containing the capsule or the Bowman's capsule and the glomerulus, the coiled arteries inside it. Okay, so this whole structure is the nephron where the filtration will happen. Now you can see over here that blood is entering. You remember the path going back over here, going back to this, yes, this one. Blood came from the heart and entered into the glomerulus. I talked about this one. Now we are talking about this blood through the afferent arteriole entering into the glomerulus. So going back over here, this is the glomerulus. This is the glomerulus and the blood is entering over here. Okay, so filtration happens right here, and then the filtrate, when I say filtrate, that means what got expelled out. And then out through the urethra and then out as urine. Okay, now the bad substances go like this and through the urethra out. But I told you that we will only remove B and D. A, C, and E, we are going to return it back into the body. So after the filtration is done, the bad substances get out. But the good substances, they are returning back like this. They are returning back. Oops, sorry. It's not shown in the diagram. Okay, they are returned back and they will eventually come back to the heart. They will eventually come back to the heart. The good substances, they are not returned, they are not filtered out through the PCT, DCT. They will not go out as urine. They will be returned back into the heart. And I showed you that over here. Going back to this slide, this one. Yes, after the filtration happens, the good substances that we don't want to throw out, they will return through this pathway. They will return through this pathway back into the heart. Okay, so let's look minutely at the nephron. So there are two types of nephron, as I told you. Cortex and medulla. So the nephrons that are present in the cortex, this part, they are 85% in number, and they have short nephron tubules. As you can see, this is the cortex part, this is the medulla part. Okay, in the cortex, these are short nephron tubules, but in the medulla, the tubules are quite long. That's the difference. These are called as cortical nephrons because they are present in the cortex. The other guys, the other ones that are present in the medulla, those nephrons are called as juxtamedullary nephrons. Juxtamedullary nephrons, and they have long loops. They have long loops like this. The cortical ones have short loops. Okay, but in this one, the juxtamedullary, the urine is more concentrated in the juxtamedullary nephron. And so where more filtration happens, is it the cortex or the medulla? More filtration happens in the cortex because they have 85% nephrons. Okay, so more filtration is done in the cortex, but more concentration of urine is done in the medulla. More thick consistency of urine. When you say more concentrated urine, it means less water in the urine. Less water in the urine. That means suppose 10 ml of urine came. 10 ml of urine came. Over here, 8 will be returned back to the body. Only 2 ml will be produced as urine. Very, very concentrated urine. If you, out of 10, if you remove 6, then the homeostasis condition of the body will be affected. You're losing more fluid. You will get dehydrated. Okay, and when you get dehydrated, because blood contains water, majority of it, if your blood is losing the fluidity of it and the homeostasis is imbalanced, then our brain will not also stop getting the oxygen and the glucose that it needs. You're going to feel a headache, a pressure tensile headache, and you're going to feel dizzy. And when you take water, because your sodium, potassium ions are also going to get disrupted. So that is why kidneys know how much they have to concentrate. So the concentrated part, making the urine thicker, returning the water back into the body, is done by the medullary nephrons. However, more filtration is done in the cortical part because there are more nephrons present structurally in the cortex. I hope it is clear. So nephrons, what we understood, it consists of the renal corpuscle, which is the glomerulus, the ball of arteries, and then a capsule around it called as the Bowman's capsule. Next, fenestrated glomerular endothelium. We're going to read about it a little bit in detail. It allows the filtrate to pass from plasma into the capsule. Let's look at this one. Okay, so the glomerulus is the main junction where the filtration is happening. So where the filtration is happening, it is getting rid of the bad substances and retaining the good substances. It will take back A, C, and E. It will remove B and D. So bad guys have to go, good guys have to stay back. Filtration is very crucial. So to have filtration, the Bowman's capsule is having 2 unique layers. The outside layer is called as the parietal layer. And you are acquainted with parietal and visceral because we did respiratory system. So now the parietal layer, it is made out of simple squamous epithelium, just simple flat layer of epithelium. But the visceral one, it has specific cells called podocytes that have legs called pedicel. And these specialized cells, I'll show you over here, they have what is called filtration slit. It's like a window, okay? It is like fenestrated. It is fenestrated. I think you read about fenestration in the respiratory system when we were dealing with alveoli. So over here, this is also same type, having filtration slit or fenestrations. So the visceral layer, so the top layer is parietal, and the visceral layer, visceral is the more internal layer, that is having specialized cells called podocytes. Podo means foot, okay? It's like a foot. See how it looks like somebody's foot or feet. So that's a podocyte, and it has fenestrated endothelium of the glomerulus, and it has slits. So through the slits, the filtration will happen. So that is the filtration membrane of the Bowman's capsule. So look over here. This is the glomerulus we are talking about, okay? And the afferent, blood is entering through the afferent. It's going to pass like this, and then going to get out through the efferent. Now, when the blood is coming and it is passing through these capillaries are having such kind of filtration slits. Look at the fenestration. How beautiful the pores are present. Through these pores, cytoplasmic extensions of podocytes. Okay, podocytes, a podocyte has a podocell or a foot-like structure. And through these fenestrations, what is happening is filtration will take place. Foot processes of podocyte. Okay, so microscopic anatomy of the kidneys, the nephron, the collecting system. I explained to you about the glomerulus, Bowman's capsule, and the wall, how it has fenestrations or slits for the filtration to happen, squamous epithelium, which is called as the capsular outer layer, and the visceral layer, which covers the glomerular capillaries. Now the space between the parietal layer, the outer parietal, and the inner visceral. This is the inner visceral. So the space between these two is called as the capsular space. Capsular space. Why capsular space? Because here's the glomerulus, here's the Bowman's capsule. This is the capsule, okay? The outer covering capsule. So this space is called as capsular space. So the visceral layer of glomerulus consists of cells with complex processes or feet, and these cells of the capsule are called podocytes, and their feet are called as pedicel. So foot and pedicel, podocyte and pedicel. Okay, and they have these gaps or slits in between the feet. These are gaps or slits through which the filtration will happen. So this is how it looks, the fenestrations between the pedicels. This is how the slits look. Now, there are certain specific cells. They are called as intraglomerular mesangial cells. Intra means between the glomerular capillaries. And these cells exist, they are called mesangial cells. They are located between the glomerular capillaries. That's why the word intra. So what are they? They are specialized, derived from smooth muscle. Whenever you see smooth muscle, you would know that it's something to do with the diameter. So functions of these cells include support and filtration and phagocytosis, but more than anything else, their contraction decreases the diameter of the capillaries. So here comes pressure management. Pressure management. So if they have to control the pressure or try to adjust, the real word not control, the real word would be adjust. If they want to adjust the pressure, then the diameter has to be altered, adjusted, changed. And that is done because of the intraglomerular mesangial cells having the capacity, due to the smooth muscles that they have in their walls. These smooth muscles will contract and change the luminal diameter, and that is going to change the blood pressure and control the blood volume, which we will see when we do the functioning. So remember that the glomerular capillaries are fenestrated capillaries because they help in filtration through the slits, but they also contain these kind of cells in between the capillaries that have the capacity to control the diameter and adjust it so that they can influence the pressure changes or pressure differences. During filtration, which takes place in the renal corpuscle, blood pressure forces the water and dissolved solids out of the capillaries through this membrane and into the capsular space. Where is the capsular space? I told you that in the kidney, if this is the glomerulus, each one has a capsule or the Bowman's capsule. This space between the glomerular capillaries and the outer capsule, this space is called as the capsular space. Okay, so basically what is happening, let me take a slide and show it to you over here so that you don't get confused. Okay, so we are looking at nephron. So we are talking about glomerulus, and we are talking about the PCT and the DCT, or the renal tubule. Okay, so glomerulus plus renal tubule makes the nephron. We're talking about glomerulus. What is glomerulus? It is consisting of a capsule or a Bowman's capsule, and it is having a group of capillaries inside it. Okay, it is having this region, this part is called as the capsular. It's called as the capsular space or the capsular cavity. So blood, when it comes, it is going to pass through these capillaries, and it is right here where the filtration will happen. And then once the filtration is done, the filtrate, which has the bad substances, okay, the filtrate is going to move from the capillaries into the capsular space. That is what is mentioned over here. It's going to go into the capsular space, and then from the capsular space, it's going to enter into the PCT. Then it's going to go through the loop of Henle, and then it's going to go through the DCT, and then through the collecting tubule, and then through the ureter, and then flushed out as urine. Okay, so blood enters, filtration happens in the glomerular capillaries. Once the filtration is done, the good substances are returned back. The bad substances, which we will call as the filtrate, they will enter into this capsular cavity or capsular space, and then from the capsular space, they will enter into the PCT, loop of Henle, DCT, collecting duct, ureter, urethra, and out. Any questions? Any questions? If you have any questions, if you don't have questions, we'll move into the next slide. Okay, thank you. So, renal tubule. The renal tubule may be 50 millimeter, you don't need the measurements. The tubule has a PCT and a DCT, a U-shaped loop of Henle. We talked about that as the filtrate. So whenever I use the word filtrate, that means filtration in the glomerulus is already done. What is coming out after the filtration, we will call it filtrate. So now it's going to go through the renal tubule. Renal tubule means the PCT, the loop of Henle, and the DCT. That's the renal tubule. Okay, so now we are going to give the filtrate a new identity. We are going to call it as tubular fluid. Why we'll call it tubular fluid? Because this is more like a tube. So when this filtrate is traveling through the tube, we'll call it tubular fluid. And it changes in composition because it's going to become more concentrated, because we only want the bad substances to be removed. We don't want the good substances to be removed. So if you only want the bad substances to be removed, you have to make it concentrated. You have to make it concentrated urine. You cannot make it dilute urine. If you make it dilute urine, it means good substances escaped from the body. And if good substances escape from the body, you know that homeostasis will be disrupted. So that is why the composition will change. It will be more concentrated urine now. Now, so we read about the filtration which is happening in the glomerulus. But I told you that all the bad substances come out, but with the bad substances, some amount of good substance also escapes. Filtration is not able to remove everything. It should remove everything, but still some amino acids come out. Some glucose may escape. Some ions may escape, which should not have been, but they come anyway. So next step is reabsorption. When you say means you have to repeat it. So reabsorption, again, try to absorb it and put it back into the body because the body needs it. So we'll go to the next step, that is reabsorption. And reabsorption means reclaim it, get it back, reclaim it. Eventually re-entering into the blood. We don't want it to go into the urine. We want it to re-enter the blood, reclaim it, reabsorb it, okay? And the reverse one is secretion. Now, many people get confused with the term secretion. They think secretion means, oh, it's a good substance, it's a hormone which is secreted. No, in case of urinary system, secretion means you are trying to get rid of the bad substance. So secretion is any extra bad substances, you're going to secrete it into the urine. Okay, so I want to add a slide over here and explain to you what I'm trying to tell so that there is absolute clarity. So nephron is going to do three things: filtration, reabsorption, and secretion. Okay, now say the blood comes and the blood has A, B, C, D, E, F, G. Okay, after filtration is done, we get A and say B, D, F, okay, G. We get all of these stuff. The rest was returned back to the body. During reabsorption, we'll see that B, D, which are actually the bad and bad, okay, these are not reabsorbed. The ones that are reabsorbed are sent back. The guys that are sent back from here are A and say F, okay? A and F are sent back or reclaimed back into body. Sent back into body. That is reabsorption, okay? So now reabsorption is completed because these guys which escaped somehow, they are sent back. A and F, they are sent back. What do we get? We get B and we get D, which are supposed to be in the urine. Okay, so now there are some other substances. So now next step is secretion. So we get B and D, and also with them we have G also coming with here. Okay, so now we need to do more reabsorption and send it back. So G is sent back, but there are suppose P present, P ion present, okay, which has somehow due to the concentration difference has escaped and come to the urine. But it has not come to the urine yet, but it is in the interstitial fluid surrounding it, but it is a bad guy. So we are going to pick it up. We are going to pick up P and add it to the urine. So ultimately in the urine, we are getting B and D and P. All of these are bad, and all of these are concentrated urine, and all of these are expelled out. So what did we learn over here? We learned that in a nephron, three activities happen: filtration, reabsorption, secretion. In filtration, good substances are returned back into the body, bad substances are expelled out into the urine. But urine has not formed yet. So we bring those substances, then we go to reabsorption. Is another step, another filtration kind of step, where reabsorption will reclaim back some more good substances and return it back into the body. We want to be double sure that we are not missing out anyone. So there's reabsorption. Now when it's ready to form urine, we are going to look around in the interstitial fluid and find that, oh, maybe there is M. Oh, maybe there is N, which is bad. So we add it to the tubular fluid. We add it to the tubular fluid. And when we add it to the tubular fluid, we get bad, worse substances. And then all of them form urine and get out. So that is why filtration, reabsorption, secretion, 3 steps. Now, filtration will happen because of pressure difference, blood pressure difference, concentration gradient difference. But when we look at reabsorption, it will make use of transport system. There will be some carrier proteins that will help in the selective reabsorption. They use the term selective reabsorption. Selective reabsorption means I'm going to select, I'm going to keep back the protein, keep back the glucose, keep back the sodium. I'm going to remove the potassium, remove the hydrogen ions, remove the urea, remove the uric acid, remove. So I'm going to decide selectively. That is why selective reabsorption, what to keep and what to get rid of. Then comes secretion. Anything else that is bad is added to the tubular fluid which is coming, and then the final addition makes it a concentrated urine. Hope this explanation will help you to understand the full concept of filtration, reabsorption, secretion. Secretion means final step of adding any bad substances. Reabsorption is like subtraction. Getting rid of the subtractant means getting rid of substances which are purely bad and retaining or reclaiming back any good substances. So we'll go to the renal tubule, PCT. What kind, to look at it microscopically, like what structure it is made out of. It is made out of cuboidal cells and it has dense microvilli. Okay, so when you say microvilli, finger-like, these are microvilli. So that means it is involved in absorption. Microvilli will provide a surface area for absorption. We had studied about the villus. I had explained to you villus while we did the intestine. So you're quite familiar with villi and villus. So dense microvilli, reabsorption, that is the work of PCT. And let's look at the loop of Henle. The descending one is thin segmented cells and the ascending one is thick one. Again, it is ranging from cuboidal cells to columnar cells. And remember the thin one in the descending limb, that is freely permeable to water. So the one that, this is the loop of Henle, this is the down and this is the up. This is the descending, this is the ascending. This guy, this one is freely permeable to water. So water can freely go back into the body, So now the DCT, the distal convoluted, it does not have microvilli. The cuboidal cells do not have microvilli. That means reabsorption is not happening in the DCT. Whatever reabsorption happened, it happened mostly in the PCT. And it mostly functions in secretion. Some amount of reabsorption could be there. I will explain to you how, but with the help of aquaporins, some reabsorption happens, but mostly it is secretion, okay? Adding more bad substances to the urine, not reabsorption, which is taking back the good substances into the body. Now the juxtaglomerular complex, that is the JGC, this is a structure that helps regulate the blood pressure and filtrate formation. So I will explain to you about JCT and how it controls the blood pressure. I will explain to that, this part. So the JGC, it is a structure right here in the kidneys. Let's say this is a part which is called JGC, juxtaglomerular cells. Now it consists of macula densa, a part which is called as macula densa. And it is, what is macula densa? It's a group of tall, closely packed epithelial cells. And they function as chemoreceptor or baroreceptor. Chemoreceptors means they are sensitive to chemical changes. Baroreceptor means they are sensitive to pressure changes. Okay, so these are modified smooth muscle cells in the wall of the afferent arteriole that secretes renin. So here comes the important hormone or enzyme renin. So renin acts both as an enzyme and a hormone in different places. So these cells function as baroreceptors that monitor the blood pressure in the afferent arteriole. So kidneys, we are having cortex, medulla, we are having nephron, everywhere nephron. And in each nephron, we are seeing that there is afferent arteriole entering and efferent going out. Afferent enters and efferent goes out. Now, on the afferent arteriole, you will find these cells, macula densa cells, are present. Okay, these macula densa cells are present on the afferent arteriole. And what are these cells? They are like baroreceptors. They can monitor blood pressure. When the blood pressure falls, BP falls, okay, when the blood pressure in your body falls, these cells which are present in the afferent arteriole of the nephron, they detect it. They detect it and they get activated and they secrete renin. So as soon as they detect that the blood pressure is going down, okay, you are having hypotension, immediately these cells, the macula densa cells of the JGC region of the afferent arteriole, they will start producing renin. Okay, this is their location under the microscope. So they will start, where did that go? Okay, they will start producing renin. Then the renin is going to start acting on other components like angiotensinogen, converted into angiotensin 1, that will get converted into angiotensin 2. It's going to impact a cascade of reactions one after the other to bring the blood pressure up. Ultimately, it's going to cause some vasoconstriction, involve the sympathetic nervous system, and help to increase the blood pressure. It was secreted because the blood pressure fell. When the blood pressure falls, renin is secreted, and then it will work through a cascade of changes to bring the blood pressure back up. It will increase the blood pressure so that it will come back to normal. We will go back to that again later on. Now let's look at the renal tubule collecting duct. So they receive the filtrate from many nephrons and they fuse together to form the papilla. I have shown this to you in the previous diagram from minor calyces. So these collecting ducts, so where is collecting duct? So here's the glomerulus, PCT, loop, DCT, this one is the collecting duct. And it's going to go into the ureter and urethra and then urine out. Okay, so we are talking about this guy, the collecting duct. They have cubital cells without microvilli. That means no reabsorption possible because they don't have microvilli. So the collecting system, this is how it moves, as I showed you, and it has, the epithelium has two main types of cells. One is intercalated cells and the other one is principal cells. And the intercalated cells are of two types. One is type A, the other one is type B. And together these cells will regulate the acid-base balance in the blood. They are cubital, they lack microvilli, okay? Some amount of reabsorption of water will happen with assistance through aquaporins, but majority, they do secretion. They don't do reabsorption, they do secretion. Oops. Hello, are you able to hear me? I just lost the connection for 1 second. Okay. Thank you, Harvey. Thank you. Okay. So, yeah. So the collecting duct, it has two types of cells. One is an intercalated cell, the other one is principal cell. And remember, these cells do acid-base balance in the collecting duct. Now, they don't have microvilli, which means they don't do too much of they don't do reabsorption. They do very little reabsorption, and that is through assistance. I will explain about aquaporins later on in the subsequent slide, but they do secrete potassium ions, and potassium ions are bad. Okay, with the urine, we are going to get rid of potassium ions. We don't need potassium ions. So the secretion means adding the potassium ions back into the urine, and that is secretion, and that is done by the collecting system. So over here, it completely shows you, this is the histology part or the tissue. Which part has which tissue? The capsule, that is parietal layer. The capsule has a visceral layer. Remember the podocytes I talked about, the fenestration, you will find that. So this is the capsule of the nephron. Then the PCT, it is having microvilli because it's going to do a lot of reabsorption. Then the DCT, look over the cells that are present. Then the loop of Henle, thin segment, and then finally the collecting duct, which has principal cell and intercalated cell. It does some acid-base balance. Mostly it does secretion. This is reabsorption. This is filtration. Okay, and DCT does some amount of reabsorptions with assistance, and I will explain that to you. Types of nephron, 85%, as I told you, are cortical nephrons. Okay, they have a short loop, and the remaining 15% are juxtamedullary. They are the nephrons present in the medulla, and these are connected to peritubular capillaries. Short nephrons connected to peritubular. At the beginning of the class, I had explained to you. These are long nephrons connected to the vasa recta. Okay, I hope this is clear. So in the kidney, again, this is the cortex, this is the medulla. So nephrons which are present over here are short, and they are connected to the peritubular capillaries. Nephrons present over here are long, but they are connected to vasa recta. I am talking to you about this one again. I'm talking to you about this slide. Okay, while the blood is returning back, either it is through the cortical nephrons, so it is going through the peritubular capillaries, or it is going through the vasa recta, because those nephrons are present in the juxtaglomerular part, and then it joins with cortical radiate and goes like this. Okay. Okay, so here it shows you everything in detail, how the blood is entering through the afferent arteriole. Look over here, it is entering through the afferent arteriole, then it is following the same pathway, whatever I explained, through the segmental artery, the interlobar artery, the arcuate artery, the cortical radiate artery, then it goes through the glomerulus, and once it goes through the glomerulus, filtration is done over there, and then either it goes through the peritubular capillaries in the cortical part, or it goes down through the medulla part. I call this as the shirt, and I call this as the pant. That is the way to remember it. Okay, so the shirt part would be the cortex part, and it will involve the peritubular capillaries. The pant part would be the medulla, and nephrons over here involve the vasa recta. These are short nephrons, these are long nephrons. So glomerulus, blood is coming through the afferent arteriole. Main filtration happens in the glomerulus. Then after the filtration, it goes to the efferent, and then it takes the path to enter into the vein. Specialized for filtration, blood pressure in the glomerulus is high. This is important. How does the filtration process happen in glomerulus? What is the motivating factor? What causes the filtration? The filtration is done because of blood pressure gradient difference. What does it mean? It means that the afferent arterioles have larger in diameter than efferent arterioles. Here we are going to remember what we studied about the chapter blood vessels. Remember when I talked about blood vessels, I explained to you about the diameter and the length of the blood vessels. And I told you that if a blood vessel has a bigger diameter, a wider diameter, the blood flow, I'm not talking about blood pressure, I'm saying blood flow would be more because the diameter is more. The wider the pipe, more flow of blood will be there. The pressure may be less, but the amount of blood coming would be more flow. Now this is afferent. They have wider diameter, bigger diameter. Then it goes through the glomerulus and it comes out through the efferent. Afferent, glomerulus, efferent. Now the efferent has narrow diameter. So if there is narrow diameter, that means less blood will flow through it. So blood flow decreases. Okay, that means the pressure will be more. The flow is reducing, but because the diameter is narrow, high pressure blood is coming. So you can see here blood entering through the afferent and blood going through the efferent. They're not the same pressure. There is a difference in pressure. There is a difference in flow. There is a difference in diameter. And that is why it creates a pressure gradient, a pressure difference. And that is all that we need for filtration. Because when there is such kind of a pressure difference, then the filtration can happen very smoothly across the glomerular capillaries. Okay, this pressure gradient is not used in the loop of Henle when reabsorption happens or when secretion happens. We don't need pressure gradient there because we are going to use carrier proteins as transporters for that work. Keep it aside for now. For glomerular filtration, we have to remember three things. Afferent arterioles have wider diameter than efferent arteriole. More blood enters through the afferent compared to the amount of blood that flows through the efferent because its diameter is narrow. And then there is pressure difference that happens because of the diameter. So pressure, flow, diameter, they cause a pressure gradient, a pressure difference, and between high and low pressure difference that facilitates or helps in filtration. Any questions? Because this is the most important part. Okay, thank you. So now let's look at the nephron capillary beds, the peritubular capillaries and the vasa recta. If you look at the peritubular capillaries, they have low pressure porous capillaries adapted for absorption, arise from efferent arterioles, and they cling to adjacent renal tubules. So this part would be these capillaries. These capillaries are in the cortex region. If you look at the vasa recta, these are long vessels and they are parallel to the loop of Henle. They arise from different arterioles and they are in the medulla. So this is the shirt and this is the pant. Okay, this is the cortex, this is the medulla. Just a difference in their structure and functioning. So functions of nephron: filtration, reabsorption, secretion. Whatever I explained to you, all of that is mentioned over here. Filtration, we'll just go over it briefly. Blood pressure, I told you this is the blood pressure, the pressure gradient. It will force the water and solutes across the walls of the glomerular capillaries and into the capsular space. So right here, kidney, here's the glomerulus, okay? Blood enters, solute containing water and solute, it enters. Filtration happens right here. Filtration happens in the glomerulus. Once the filtration is done, the liquid that comes out will end up in the capsular region. The capsular region, which is between the capsule and the medulla part. So the fluid now goes into the capsular space. Solute molecules small enough to pass through the filtration membrane are carried by surrounding water molecules. So filtration is completed. Next step is reabsorption. It is the removal of water and solutes from the filtrate. So now we are going to call it as filtrate. What came out is the filtrate, but it still contains some good substances, which we are going to reclaim and put it back into the system through the process called reabsorption. Filtration is done because of particle size. Reabsorption is a selective process. We decide what we are going to reclaim, take it back into the system, and what we are going to throw out of the system. That is why reabsorption is a selective process. But filtration is not involving any choice. It's just size particle. Big particles like protein cannot cross the filtration membrane. RBC, glucose, protein, these substances are not supposed to get out of the body. They need to be put back into the system. So they don't, the big protein chunks never cross the filtration membrane of glomerulus. Now, if the person has diabetes for 30 years and his filtration mechanism has become weak and there is poor kidney function because of chronic CKD disease, then the proteins will leak through the filtration membrane, which they should not do in a healthy person. So they will leak, and when they leak, they will show up in the urine, and the urine report will say albumin present. And these are signs of poor kidney functionality. Secretion. Secretion is the transport of solutes from the peritubular fluid across the tubular epithelium and into the tubular fluid. So secretion is just the opposite of reabsorption. We are going to take the bad substances and put it back into the tubular fluid. What is tubular fluid? That is the fluid present in the loop of Henle, which is getting ready to form urine and be flushed out. We are going to add bad substances into the tubular fluid, okay? And tubular secretion removes substances from the blood, and they can further lower the concentration of undesirable materials like drugs, and it is a backup process for filtration. So things that were missed out in filtration, okay, they will be added back, like drugs or alcohol or chemicals or food coloring agents. These can be added back to make it concentrated urine. Cortical nephrons do most of the reabsorption. We know that because they are 85% in number compared to the 15% is seen in the juxtamedullary nephrons. And the juxtamedullary nephrons enable the kidneys to produce urine storage and eliminate the concentrated urine. Function of the filtration membrane. Okay, so this part I already explained to you that the fenestrated endothelium, the basement membrane, the foot processes or podocytes, we already discussed about it. That is just explained over here. Now, let's look at the pressure. I told you that there is some pressure difference, and because of that pressure difference, filtration is possible. Solute size matters through the filtration membrane, but the pressure is a very crucial part. We are going to study about 3 different kinds of pressure that acts through the glomerulus. Number 1 is hydrostatic pressure. So at the glomerulus, you will find that there is a pressure, and that is called glomerular hydrostatic pressure. It is about 50 millimeter mercury pressure. That is called GHP. At the glomerulus, blood leaving the glomerulus capillaris flows into an efferent glomerular arteriole, we already discussed that the diameter of the efferent is smaller than that of the afferent. I showed you how the diameter changes, so the pressure changes. I already explained that. The pressure has a name for it, and that pressure is called glomerular hydrostatic pressure, and it is 50 millimeter mercury. Then, so if this is the glomerulus, here's the capsule. Our objective is blood should flow in, filtration will happen, the remaining blood is sent back, afferent, efferent, remaining is sent back. After the filtration, what comes out is joining the PCT, loop of Henle, DCT, okay? So filtration is happening right here at the glomerulus. The pressure that is exerted in this forward direction is the glomerular hydrostatic pressure, and that is 50 millimeter mercury pressure. I already explained to you how that pressure develops because of the difference in diameter of the afferent and the efferent. So this is called glomerular hydrostatic pressure, 50 millimeter. The capsular hydrostatic pressure, CSHP, it opposes the GHP. It opposes means it is going to come out in the opposite direction. From the capsule region, it's going to oppose it. Okay, so this is the capsule. This is the capsule. So the space right here, this is the capsule. So the pressure present over here of the fluid that is already there, it's going to offer some resistance to the GHP in the opposite direction, and we'll call that as CSHP, or capsular hydrostatic pressure. And the CSHP is about, say, 15 millimeter mercury pressure. That is the capsular hydrostatic pressure, which is opposing it. It is the resistance to flow along the nephron and conducting system. So what do we get? The net hydrostatic pressure. We subtract it. The opposing one, we will subtract it. So the net hydrostatic pressure, well, how much would be? It is 35, because GHP is 50 and GHP is acting in this direction. CSP is acting in the opposite direction. GHP is 50, CSHP is 15. So when you subtract 50 minus 15, the net hydrostatic pressure would be 35. Okay, the net hydrostatic pressure would be 35. So again, so this is the glomerulus. Afferent is coming, efferent is going away, AFF, EFF. Now, after the filtration, what is going here is through the PCT, loop of Henle, DCT, and the urine. Blood comes and blood returns. Filtration happens here. Only substances that are bad will get filtered through the tubular filter and go out as urine. Okay. Now, the outside covering we know is the capsule. There is fluid over here already, which is offering a resistance. Because of the diameter differences, some pressure is formed, a pressure concentration. So we call this forward pressure as glomerular hydrostatic pressure, and that is 50, minus the capsular pressure, which is offering a resistance to the flow. When the blood flow is coming, it is offering a resistance, and we call that as capsular hydrostatic pressure. Okay, and that is around 15. So the net hydrostatic pressure, would be 50 minus 15, that is 35. So now in the exam, they might ask you that for a person, the glomerular hydrostatic pressure is 45 and the CSHP is say 10. What is the NHP? You have to calculate it. Okay, so just simple subtraction. This is coming in the forward direction. This is coming in the opposite direction. It is opposing the flow of blood, and that is why it's already the blood present in the capsule. So because of the pressure difference, some pressure difference will the pressure is coming in the left side, the pressure is coming from the right side. The end result is filtration through the capillaries. Now there is also a third pressure. The third pressure is called colloid osmotic pressure. This is like the BCOP that we studied when we were talking about blood vessels. So the BCOP is the osmotic pressure of the proteins in the blood. The solutes that are present in the blood, these solutes present in the blood, they also throw a repelling action. They also throw an opposing force to the forward movement of blood, and they are called BCOP, or blood colloid osmotic pressure. Okay, and then this blood colloid osmotic pressure has to be subtracted from the net filtration pressure. This is the net filtration. This is the net filtration. We got 35. GHP minus the opposing capsular, we got net filtration as 35. From the 35, we are further going to deduct 25. From the 35, we are going to deduct 25. So finally, the end pressure is only 10. So NFP we got as a product of these two. This minus this, we got NFP, net filtration pressure. But that's not the final pressure. There is also opposing force in the opposite direction, which is the BCOP, blood colloid osmotic pressure. It is opposing. So now what we do is we'll take the filtration pressure and subtract the BCOP so that we'll get the final net filtration pressure as, we'll take the net hydrostatic, so sorry, this is the net hydrostatic pressure. This is the net hydrostatic pressure, NHP. We got it subtracting this and this, we got NHP, net hydrostatic pressure. minus the blood colloid osmotic pressure, the opposing pressure given by solutes in the blood. When you subtract these two, 35 minus 25, what you get is the net filtration pressure, that is 10. Is this clear? This is all about the three pressures which are present in the glomerulus. Did you understand this part, or do you want me to explain it again? Okay, so we'll go next to the glomerular filtration rate. That is the amount of filtrate the kidneys produce each minute. It averages around 125 milliliter per minute. That is the speed at which the filtration is happening at the glomerulus. Now, normally it is 125. As a person increases in age, it will gradually fall down to 80s and 70s and 60s or maybe 50s. And then if the lesser it is, that means the kidneys are not functioning as well as they should. So the filtration membrane, we already discussed about it. I told you about, this is the filtration membrane present in the glomerulus. I told you about the fenestrated means with window-like slits. We talked about the podocytes, the foot processes, and how the filtration occurs through them. We discussed this diagram and I showed you this particular fenestration or pores. So we are done with filtration membrane. This is an image of the filtration membrane and it is more clear over here. It will show you the foot processes of podocyte, of glomerular capsule, the capillary endothelium, the filtration membrane, the slits. Look over here, how the slits are opening ways for the filtrate to pass through it. So now comes the kidney physiology. We'll go through it again. Filtrate is blood plasma minus the proteins, because the big chunks of proteins have been returned back to the body. They never made it through the glomerulus. Then urine, it is less than 1% of total filtrate, and it contains only waste and substances that we don't need. It's very, very concentrated. You cannot allow substances to get out of the body through the urine. Mechanism of urine formation, filtration, we just completed that. Next is tubular secretion. It returns 100% of glucose and amino acid back into the body. Reclaim, return, okay, reabsorb. So that is all done over here. And 99% of water, salt, all the components of the blood, they're all returned back into the system. Then is tubular secretion. That is the reverse of reabsorption. It is addition to the urine. Any other bad substances like drugs or alcohol or chemicals or some harmful agents or coloring food products and all those stuff, those are added back into the urine. That is tubular secretion. That's the reverse of reabsorption. So look at this picture. It will give you a clear image how the blood enters, filtration. Then after the filtration, due to the pressure difference that I explained, the remaining part goes through the PCT, the coiled part PCT. Some reabsorption happens over here, and it goes down through the descending limb, the thin one, then the ascending one, the thick one, then DCT, okay, collecting duct, and finally urine is eliminated. So during filtration, large amounts of blood are filtered every day. So glomerular filtration rate is around 125 in the normal person. And I explained to you how the hydrostatic and the osmotic pressure plays a role. That means the glomerular hydrostatic pressure and the blood colloid osmotic pressure. Hydrostatic pressure, that is the glomerular hydrostatic pressure, we just discussed about it. It is around 50. And when the blood flows like this through afferent, glomerulus, and efferent, the hydrostatic pressure in the glomerulus is high due to the fact that efferent is more constricted relative to afferent. I already explained to you that afferent has a narrow diameter, has a wider diameter, and the efferent has a narrow diameter. And because of this diameter difference, it generates a hydrostatic pressure, which is around 50 millimeter mercury pressure. So this diagram over here will give you the complete explanation of the glomerular hydrostatic pressure, 50 to 55. Look at the purple arrow. It comes in this way. To it, there are two pressures which are opposing in the opposite direction. One is this light blue one, capsular hydrostatic pressure, that is 15, and the other one is green, which is also opposing. When this is coming in this direction, these two are opposing. So we have one arrow coming GHP, and then we have two opposing it, one is BCOP, okay, and then the capsular hydrostatic pressure, okay. So these two are opposing, whereas this is opposing the GHP. And then the final result of this filtration is the net filtration pressure. Net filtration pressure, and that is 10, that moves in this direction to the PCT. So hydrostatic pressure, glomerular hydrostatic, depends on the diameter, as I explained to you. If the afferent arteriole will dilate and constrict the efferent, hydrostatic pressure in the glomerulus goes up. So question for you here, if the afferent arteriole will dilate and the efferent arteriole will constrict, what will happen? The hydrostatic pressure will go up. But if the afferent one is going to constrict means narrow diameter, that means blood flow will decrease and the efferent one will dilate, okay, then the blood pressure will go down. Hydrostatic pressure always pushes the fluid out so that it will move into the PCT. This is the blood colloid osmotic pressure, and it works in the opposing direction. It opposes the glomerular hydrostatic pressure, and it's because of the colloid or the solute or the protein which is present in the blood, and it always, protein albumin always pulls water back into the blood with a pressure around 25 millimeter mercury pressure. So it always tries to pull the water back into the blood. So here is a summary of the net filtration pressure. So we are looking at hydrostatic, this is the glomerular hydrostatic pressure, 50, minus the blood colloid osmotic pressure, that is 25, okay? And then we are looking at the capsular hydrostatic pressure, minus 15. So altogether, so 50 minus this 25 minus this 15. Then finally you will get the net filtration pressure. So this one is the same diagram repeated. So what is filtered? Blood is pushed out due to the higher hydrostatic pressure to make the filtrate. And so filtrate is now plasma without proteins, WBC, RBC, platelets, all of these are filtered and retained back or returned back into the system. So what comes out is now called as the tubular fluid. These cells are too big to pass through the fenestrated slits between the podocytes of the glomerular capillaries, so they are sent back into the system. So if you look at the filtration membrane, we know that it has a simple squamous cell, basement membrane, and there are slit between the podocytes. So here it shows you the filtration slit and the filtrate which is present in the capsular space that provides the opposing force. So ultimately it shows you how the filtration happens and how the fluid or the blood comes out through the glomerulus, not allowing the protein chunks or the big pieces to enter into the filtrate. So here is a summary of whatever we discussed. Now, regulation of the GFR filtration depends on adequate blood flow, and 3 interacting levels of control ensure that the GFR remains within the normal limit. So GFR is the glomerular filtration rate, and I said that it is controlled, and normally in a normal person it is around, the rate is around 125 milliliter per minute. Now it is influenced by autoregulation. Either you can do autoregulation at a local region, or there is some kind of a hormonal influence on it, or there is a nervous control through the autonomic nervous system or the sympathetic division of the ANS. So autoregulation, hormone regulation, ANS sympathetic division. All these three can influence the pressure. First of all, the autoregulation. And we know that the GFR, despite changes in local blood pressure, it will try to maintain a constant blood pressure in the glomerulus by myogenic mechanism. So how does this myogenic mechanism work? I told you that the glomerular capillaries, in between them, they have mesangial cells. Going back to that slide previously, we talked about mesangial cells between the glomerular capillaries. Now, these mesangial cells, they have actin-like filament and they can contract. In this way, these cells control the diameter and the rate of glomerular capillary blood flow. So this is how the glomerular capillary blood cells, or also called as the intraglomerular mesangial cells, they have smooth muscle. And so whenever there is smooth muscle, they can contract or dilate and regulate the diameter. So in case the blood flow fluctuates, these cells can contract and control their diameter in such a way, adjust their diameter in such a way that the blood pressure which had fluctuated would get back to normalcy. This is called auto-regulation of the GFR rate. Okay, to maintain the pressure, they do some self-adjustment, and that is what we call auto-regulation. Who does it? The glomerular cells themselves. They are called mesangial cells. So that is how, because of these adjustment, the GFR remains relatively constant when systemic blood pressure increases. So even if your body is undergoing hypertension or hypotension, your blood pressure is increasing or decreasing, in spite of that, the kidneys have their own mechanism of autoregulation, of controlling their cells' diameter so that they don't change because your blood pressure is fluctuating. They will try their best to maintain a constancy, because if you're going to constantly change their pressure, the delicate filtration infrastructure is going to break down. It's going to fall apart because you keep on changing the pressure and fluctuating the high BP, low BP, high BP, low BP. The filtration mechanism is going to get affected. You need a constant blood pressure, and that is to do a good amount of filtration. That is why these cells, the mesangial cells in the glomerular capillaries, they do some kind of self-regulation, and they make use of actin-like filaments to contract the diameter and maintain the pressure. Okay, so this is one type. Then the next one is through hormonal regulation. And for hormonal regulation, they are going to make use of RAS, renin, angiotensin, aldosterone system. So as I told you that the kidneys have afferent arteriole, which has a region called macula densa. I already showed you in the previous slide that macula densa is very sensitive to change in pressure. It acts as a baroreceptor. So because it acts as a baroreceptor and it is sensitive to the change in pressure, it will, if the pressure drops, it's immediately going to secrete renin. So this renin is another hormonal regulation mechanism. Renin secretion will trigger a cascade of changes that will bring up or increase the blood pressure. So these triggers are often interrelated. A decrease in the systemic blood pressure, it will reduce the glomerular filtration rate, and baroreceptor reflex will cause sympathetic activation. It will cause sympathetic activation so that the blood pressure will again increase. So a decrease in GFR leads to the release of renin by juxtaglomerular complex, the macula densa cells of the JGC cells in the medulla. So what will renin do? As soon as renin is secreted, so first question is, why is renin secreted? Renin is secreted because the macula densa cells present in the afferent arteriole, they act as a baroreceptor and they detect that body's blood pressure is dropping. When the systemic blood pressure is falling, they detect it. Who detects it? The macula densa cells of the juxtaglomerular region. They detect it. Once they detect it, they secrete renin. Now, this renin converts the inactive plasma protein angiotensinogen into angiotensin Roman number 1. Angiotensin 1 is also inactive. So now it will convert it into angiotensin 2 by angiotensin converting enzyme ACE. We talked about ACE when we were studying about the respiratory system lungs, that the lungs have an enzyme called ACE. So now with the help of ACE, it's going to convert the inactive angiotensin 1 into active angiotensin 2. So this conversion takes place in the capillaries of the lungs. The angiotensin 2 is going to cause contraction of smooth muscle in the capillary bed. And it will also promote the aldosterone production. And it will also trigger the sympathetic nervous system so that the blood pressure will increase. So 3 things the renin will do. First thing, it's going to convert the angiotensinogen into angiotensin 1. That happens in the liver. Then it's going to convert the angiotensin 1 into angiotensin 2. That happens in the lungs. Now, this angiotensin 2 is going to come and it's going to cause 3 things. It's going to act on the smooth muscle and cause their contraction so that the blood pressure will increase. It will cause the secretion of aldosterone hormone from adrenal glands so that sodium reabsorption will happen. And once sodium is reabsorbed, water will follow sodium. So volume will increase, more sodium will be retained, blood pressure will increase. Now, because you need more pressure to push more volume of blood, so blood pressure will increase. And then the third thing it does is it activates the sympathetic nervous system. When you activate the sympathetic nervous system, it's going to cause vasoconstriction and increase the blood pressure. So I can put it this way, it's like a cascade of reactions. Let me take a slide and draw it for you over here and show it to you. Okay, so we are having the kidney, cortex, medulla. Okay, suppose this is the one nephron's glomerulus. Here's the afferent arteriole. Afferent arteriole is having the juxtaglomerular region macula densa cells. Okay, macula densa cells, they are baroreceptors. They can detect any change in blood pressure. So body's blood pressure drops, BP falls. BP falls. It's detected by the baroreceptors of the kidney and they immediately secrete renin. Renin is going to go and convert the plasma protein angiotensinogen, that's inactive, into angiotensin 1, that is also inactive, happening in the liver. Then angiotensin 1, this guy, is converted into angiotensin 2. This is active, and this is done by the help of ACE enzyme in the lungs. Now we got angiotensin 2, which is active. This angiotensin 2 has 3 works. It's going to change the diameter of the smooth muscles, okay, of the capillaries and increase the blood pressure. It's going to act on the adrenal gland and produce aldosterone secretion so that it's going to cause sodium reabsorption. It's going to increase sodium retention. So water is going to follow sodium. So the volume will increase. And because you need more pressure to push more volume of blood, so now the blood pressure increases. So it's going to act on adrenal gland. It's also going to activate the sympathetic nervous system and do vasoconstriction so that the blood pressure increases. So our story started because blood pressure had fallen. Now, through the activity of renin, through the activity of these 3 steps, vasoconstriction through the sympathetic, secretion of aldosterone and retention of sodium, increasing the blood pressure, and then also through the diameter of the capillaries constricting, through all of these 3 mechanisms, the blood pressure now increases, it rises up. For a short-term cause, RAS mechanism is good. It will always try to bring the blood pressure up. But if it becomes a chronic thing and keeps on happening all the time, then it becomes an issue. Next, so this is all about RAS. Next is ANP. The heart releases natriuretic peptides, okay? atrial natriuretic peptides, and these atrial ANP, what they do basically is they cause dilation of afferent glomerular arterioles. Whereas renin is doing vasoconstriction, this guy does more of dilation of the afferent glomerular arterioles and the constriction of efferent glomerular arterioles. That is the work of ANP. So this is the diagram showing you the juxtaglomerular apparatus of the JGA that helps in the secretion of renin. So renin is secreted when flow to the nephron is reduced, and if the flow of the nephron is reduced, less urine is filtered, and it will help to increase the blood pressure, which increases the urine production. So if you look at renin, what it does, I already explained to you, it goes to the liver, angiotensinogen that is inactive is converted into angiotensin 1, and then it travels to the lung where it converts it into angiotensin 2 with the help of the enzyme ACE. So if you look at renin, blood pressure is falling, dropping. So renin is secreted, it converts this into this, into this. Then this guy is going to cause blood pressure to increase through aldosterone by activating the adrenal to secrete aldosterone that will cause sodium to be retained and help in increasing the blood pressure. So our condition was blood pressure had fallen through the activity of renin. Now the blood pressure is up. So JGA, it increases the blood pressure when blood pressure is low by acting through renin. It assures that we have sufficient blood pressure to make urine. Because if your blood pressure drops, the urine filtration process will slow down and toxic substances will accumulate in the body. How can we stop this process? Well, if you take ACE inhibitors, they're a class of high blood pressure medication. It blocks the ability to make angiotensin 2. Principles of reabsorption and secretion. 4 major types of carrier-mediated transport mechanisms are there. So this you should just know that in case of facilitated diffusion, facilitated means you take some amount of help, okay? A carrier protein will help in transporting. Then there is active transport that is mostly done with hydrolysis of ATP, and that uses energy. In co-transport, 2 substrates, they will cross the membrane while bound to a carrier protein. And then counter transport, that means one is going in this direction, the other is coming in the opposite direction. That is counter transport. And counter transport operates in PCT, DCT, and collecting system. So we'll use some amount of facilitated diffusion, some amount of co-transport, some amount of counter transport. All these transport mechanisms, because we are done with filtration, we are done with pressure differences. Pressure differences, filtration, we talked about it in the glomerulus. Now we are looking at reabsorption. Now we are looking at the carrier proteins which will help in the reabsorption process. So transport maximum, 100% of glucose and amino acids are always reabsorbed due to the presence of microvilli, and that is done by facilitated diffusion. Water will follow them. Okay, we don't want to see glucose and amino acid in the urine. We don't want to see them. They are good substances. They need to be returned back to the body. They need to be reclaimed back. And that is done because we talked about microvilli that is present where reabsorption takes place. Only limited number of carriers to move glucose back into the blood. So if you take too much of glucose and sugar diet, you have very less transporters, protein transporters, that can rescue the glucose back into the body. Because if you're taking too much of glucose, that might spill over into the urine because that threshold is met. Like 20 people can cross the lake and there are 20 boats, there are 20 ships to carry them. But if you come as 40 people, then 20 ships are full, packed. Then you have no way to cross it, then you will have to be kicked out as urine. And that is when sugar or blood glucose ends up showing up in the urine. and you get a call from the doctor because your urine showed glucose. That means you're consuming so much of glucose that there's not enough transport proteins to bring it back, return it back into the body, and they begin to show up in the urine. So that threshold, it meets that it crosses over the threshold, and so it will spill into the urine. Transport maximum, the amount of substance that these carriers can handle, the maximum amount. If there are 20 people, there are 20 ships to carry them back. If you come as 40 people or 60 people, there are not that many carrier proteins. In that case, you end up in the urine. So when a carrier protein is saturated, further increase in substrate, like you're taking too much of glucose, more and above, then you are beyond that maximum capacity. You cross the threshold value, and then you begin to appear in the urine because you're taking so much of sugar. So reabsorption and secretion along the PCT. So reabsorption occurs along the PCT. 60 to 70% of the volume of the filtrate produced in the renal corpuscle. The tubular cells will reabsorb organic nutrients. What all they absorb? Nutrients, ions, plasma protein. In case some have leaked into the tubular fluid, those are sent back, and they will diffuse into the peritubular capillaries in the cortical region and into the vasa recta in the medullary region. They're all returned back into the system. So the PCT, there is a lot of glucose, amino acid, sodium, water. These are all reabsorbed from the tubular fluid sent back into the system thanks to the microvilli. Reabsorption of organic nutrients. So under normal circumstances, when it enters, PCT will absorb 99% of glucose, amino acid. Active reabsorption of ions, it's going to absorb sodium, potassium, bicarbonate, magnesium, phosphate, sulfate, all of these sent back into the system. It also recaptures around 90% of bicarbonate. Now, bicarbonate ions act as a good buffer, and the body needs it as a buffer to neutralize the acids and the bases. That is why we can't let go of bicarbonate ions. They are also reclaimed, reabsorbed back. Reabsorption of water. So PCT, that actively reabsorbs water. Okay, a lot amount of water is reabsorbed. Passive reabsorption of ions. So passively also act, not only actively, also passively by osmosis. A lot of substances, good substances, solutes are returned back. Then secretion. We don't need these hydrogen ions. We don't need potassium ions. Those are secreted into the tubular fluid to be added to the urine. The sodium ions may enter tubular cells by diffusion through sodium leak channels, and they are tagged up with the glucose, and by counter transport of hydrogen ions, in exchange for hydrogen ions, they are sent back into the system. So if you are looking at reabsorption, PCT, the microvilli, that will do 65% of reabsorption in the PCT. The loop of Henle will do 25%. Sodium, potassium, chloride, that will happen in the loop of Henle. DCT will do fine tuning. The last 20% of water will be completed in the DCT. So reabsorption of sodium. Always remember the golden rule, water follows sodium. Water follows sodium. So if you are eating too much of chips and junk food and too much of salty diet and pickle and sauce and eating outside with a lot of salt, because salt is added as a preservative. If you're eating more of salt, you're going to retain water, and you're going to be puffy and swollen up because water is going to get retained, more reabsorbed into your system. So glucose and sodium are co-transporters. Both get reabsorbed together. Amino acid and sodium are co-transporters. Both get reabsorbed. Sodium and hydrogen are antiporter. That means when sodium moves back into the blood and it is reclaimed back, hydrogen moves out of the blood and gets added into the urine. That means it is secreted. Sodium, potassium chloride, they're symporter. They move together into the blood, reabsorption in the ascending limb of the loop of Henle. But so in the ascending limb, you're going to find sodium, potassium chloride are friends. They are friends in the ascending limb going back into the body together. But in the DCT, you will find that it is antiporter. So question for you over here, in the ascending limb, sodium, potassium are what kind of transportation? Symporter. But in the DCT, you will find that they become antiporter. Sodium is taken inside by reabsorption and potassium is kicked out or secreted into the urine. So sodium and glucose, symporters happening in the PCT. Sodium and amino acids, symporters in the PCT, going hand in hand together as friends back into the system. Sodium and hydrogen ions, antiporters in the PCT. This goes in by reabsorption. Hydrogen goes out by secretion into the urine. In the loop, sodium, potassium are symporters, but in the DCT and the collecting tubule, these are anti. Sodium goes in, potassium goes out. Any questions? Okay, so if you don't have any questions, thank you. We'll go into secretion, which is the last part. What is secreted out? What goes out in the urine? We have urea, creatinine, some amount of potassium, penicillin, drugs, alcohol, chemicals, food coloring agents, all of the bad substances, they're going to get secreted out. So whatever I explained, the whole explanation is mentioned over here. Yeah, it is the site for active secretion of ions, drugs, toxins, selective reabsorption of sodium and calcium. So we are going to take back sodium, we are going to take back protein, we are going to take back glucose, we are going to take back calcium, take back magnesium, take back some amount of potassium, take back a huge amount of water. All of this reabsorption. What we are going to expel, we are going to expel urea, creatinine, some amount of potassium, some amount of H+. Okay, we are going to take back bicarbonate, HCO3 minus. We are going to remove creatinine, uric acid, urea, potassium, some amount of H+. So that is by secretion. So sodium ion reabsorption. The collecting system contains aldosterone sensitive ion pumps that exchange sodium ions for potassium ions. Okay, so here antiporter, as I showed you, sodium enters, potassium leaves. Bicarbonate ions, bicarbonates are reabsorbed in exchange for chloride in the peritubular. So bicarbonate is taken in, chloride is sacrificed. This goes out, this goes in exchange. Urea. The concentration of urea entering is relatively high. The fluid entering has the same osmolarity but contains a much higher concentration. Urea tends to diffuse out of the tubular into the peritubular fluid in the deepest portion of the medulla. So suppose, say 900 milligram of urea is coming. Do you think all of it's going to get out in the urine? No. Maybe say 400 is reabsorbed and the remaining 500 is expelled out. That is what it's trying to say about urea reabsorption. So filtration, we completed reabsorption and secretion. We did talk about renin and how it goes to increase the blood pressure, because when the blood pressure increases, it will also help in increasing the filtration, and that means urine formation will increase. So hormones that act on the kidney, antidiuretic hormone, aldosterone, this will secreted by, renin acts on the adrenal, that will cause sodium aldosterone secretion. Aldosterone hormone will cause sodium retention. So when sodium retention will happen, blood volume will increase and it will change the formation of urine. Parathyroid hormone, because of calcium metabolism. ANP, we talked about this, how the heart releases the atrial natriuretic peptide and how it causes the dilation of the afferent arteriole and the constriction of the efferent arteriole. So these are all the hormones. You may get questions over here. How does ADH influence the urine formation? What it does? How does aldosterone or sodium reabsorption change the urine formation? Which one increases blood pressure? Which one decreases blood pressure? Which one produces more urine? Which one produces less urine? I hope your concept is very clear about each one of it. If not, ask me. Or write email, I will explain to you over email. So this is the reabsorption and secretion that we talked about using the aldosterone, natriuretic peptide. and ADH role. It controls the permeability of DCT. Okay, the secretion of ADH is suppressed by ANP, and this combines with the effects of ANP and aldosterone secretion can dramatically increase urinary water losses. So you need to understand the role of ADH, antidiuretic hormone. Okay, this one will not allow water to be lost. It will retain the sodium and it will retain the water. Antidiuretic. It will not allow water to be lost. The ANP, which is secreted by the heart, it will cause the water to be lost. Just the reverse. That's what is written over here. It's antagonistic, opposite in function. This guy will preserve the water. This guy will help in releasing the water. That means more diluted volume of urine because of ANP. The next one is aldosterone. Aldosterone will cause sodium retention. Again, it will reabsorb water, keep the water inside. So now when these hormones act, each of them have a different expression on the blood pressure. Because if you are retaining sodium, water will follow. That means more volume of blood inside the body. That means the pressure will increase because it needs more pressure to push the big volume of water. So out of these hormones, ADH, ANP, aldosterone, you have to know which hormone is keeping the sodium inside the body. The one that keeps the sodium inside is keeping the water inside also. And if it's keeping the water inside, which means blood pressure will increase. Okay, but the other guy, if it is flushing the water out, if it's not keeping the water, it's flushing the water out, and there's lower volume, so the pressure, less pressure is required, so the pressure will fall. So this is how these hormones act on the blood pressure. Okay, so ADH, first of all, the antidiuretic hormone is made by the hypothalamus when the blood is too salty, major regulator of water balance. And it will do less urination and it will conserve the water because antidiuretic is going to conserve the water. Okay, so urination will be less, but since it's going to conserve the water, it's going to increase the volume of water. That means the blood pressure is going to rise because more pressure is needed to push that volume of blood. Water reabsorption, so ascending limb, DCT, collecting duct, they're all impermeable to water. Even so only the descending limb, this is freely permeable to water, the descending limb. But the ascending limb, this guy, and the distal convoluted tubule and the collecting duct, they're all impermeable to water. Even though water always wants to follow the sodium, water cannot follow. When the sodium-potassium symporter is acting, they're going hand in hand, but water cannot follow them. Because in the loop of Henle, this is the PCT, descending, ascending, DCT. Out of these, here, water can freely go in and out, free. Water can freely move in and out, freely permeable in the descending limb. But if you look at the ascending limb, no water can go, no water can go, no water can go. DCT, and in the ascending limb, water cannot go. Okay, even though sodium and potassium goes and water wants to follow them because water has always affinity for following sodium, but though sodium and potassium can move in and out freely here, water cannot follow them because it is impermeable. Now, if it is impermeable, water cannot go, but because of ADH, water can be reabsorbed. How? Because ADH, how does it work? It will add aquaporins. I told you in the previous slide that I will talk about aquaporins. This is the time I'm going to talk about aquaporins. So in the loop of Henle, PCT, descending, ascending, DCT. Here we don't need aquaporins because water can freely go out, reabsorbed. But here, water cannot. It is not permeable. Even though sodium is reabsorbed, water cannot follow it. Water cannot get out. But when the antidiuretic hormone will be secreted, okay, by the pituitary. When this is secreted, it is going to add certain passage over here by adding aquaporins, like small gate, some exit point. And that is when aquaporin is present, only when ADH is secreted, it's going to add aquaporins inserted into the membrane, and then it is going to help the water to be reabsorbed, for the water to be taken back into the vesicles. So remember, water cannot escape over here and over here. Only when ADH is secreted, it's going to add some gates over here. Those gates are called aquaporins, and through those aquaporins, water can escape and be reabsorbed back into the system. So if you don't have ADH, antidiuretic hormone, then you don't have aquaporins. And if you don't have aquaporins, your water cannot be reabsorbed. Water cannot escape. All the water that is present in the DCT and the ascending limb will end up in the urine. You cannot reclaim back the extra water. So that is going to end up as urine. So you produce a huge amount of urine. The volume of urine will increase, okay? So in people who have diabetes insipidus, they do not produce ADH. And because they don't produce the antidiuretic hormone, that is why they do not add the gateway, that is aquaporin, to the ascending limb. And so the ascending limb is impermeable to water, and water cannot escape and cannot be reabsorbed back into the system. So whatever water stays in that limb ends up in the DCT, goes to the collecting duct, goes to the pelvis, ureter, out. So alcohol and caffeine, they inhibit ADH secretion. When people take coffee, caffeine, or alcohol, then those are ADH inhibitors. They will suppress ADH secretion. So no ADH means no aquaporins. Water will not be reabsorbed. These people who take alcohol and caffeine are going to go to the toilet, restroom more frequently, and they're going to pee a lot and produce a lot of urine because water was not reabsorbed. Then they begin to feel very thirsty. So if you keep on sipping coffee all day, you're going to get dehydrated because you're producing more volume of urine, because caffeine is suppressing the ADH hormone, which is suppressing, not helping by providing aquaporins. So water is not leaking out, it's not reabsorbed. So we get concentrated urine, or what's called as a salty urine, and interstitial fluid near the papilla of the medullary pyramid is very salty. So the juxtamedullary nephrons help establish the salty medulla. Vasa recta fluid flows in the opposite direction to the urine filter. I have already explained that. So now the last part is counter current multiplication. It allows the kidneys to regulate the volume and concentration of urine. What is this counter current mechanism? You must have seen that one limb is going down, which is the descending, then it's taking a loop, and then ascending, down and ascending. Both are moving in the opposite direction, though they're parallel to each other. Okay, one comes down, the other goes up. So opposite direction, but they are parallel to each other, adjacent to each other. So that acts as a good counter current exchanger, a good counter current multiplier, because filtrate flow in the nephron loop and the blood flow in the vasa recta. These mechanisms establish and maintain an osmotic gradient from the cortex and the medulla. Because both the limbs are structurally present in such a way, they are opposite in movement, but they're parallel and adjacent to each other. Very swift exchange due to the difference in the concentration happens, and that is why we call this as a counter current. One current is coming down, the other current is like this, a counter current multiplication, a counter current exchanger. So the nephron loop and counter current multiplication, the descending limb and the thick ascending, they lie very close together. They're separated only by peritubular fluid. It surrounds all the nephrons. Well, the exchange of substances between these segments of nephron is called counter current mechanism. It refers to the fact that effect of exchange increases as movement of the fluid continues. The more the fluid gets in and reabsorbs or secreted, this multiplier continues working. So it performs two functions. It helps in the reabsorption of solute, and it makes sure that ADH is helping in water reabsorption through inserting aquaporins, all that we have discussed. And the ascending is impermeable to water and solutes, but it contains active transport mechanisms that will help in sodium and chloride transport. So counter current flow. Vasa recta takes the salt from ascending limb towards the bottom of the loop of Henle. Water cannot flow. And then sodium, potassium chloride, they all leave, but water cannot flow. Ascending means it is totally impermeable to water unless you have ADH, unless you have aquaporins added. If aquaporin added, then water can go out. And this makes the medulla very salty. So here it shows you this part. See the water that is going out and getting reabsorbed back into the body. This is all freely permeable, okay? But right here, the thick part, sodium and chlorine can get out, but water cannot follow them. Water cannot. But over here, when you bring in ADH secretion and you insert aquaporins, okay? These are like oblique lines. These are like dotted lines. These are like dotted lines. Why? Because the water is coming out, but with the help of ADH and aquaporins. So now water can get reabsorbed back. So ultimately you get concentrated urine, and presence of ADH will add the aquaporins and help to take back the water. Okay, so water will be reabsorbed in the collecting duct thanks to ADH, and then you can create a urine 4x as salty as the blood. That is water conservation. You are retaining back the water, reclaiming the water with the help of ADH. So ADH plays a very crucial part. So hormones that act, ADH, antidiuretic hormone, these hormones work on electrolyte balance because they will retain back the water. Aldosterone, sodium reabsorption. ANP would work opposite in function. I've already explained that comes out from the heart. And parathyroid would help in calcium metabolism. Aldosterone, made by the cortex of the adrenal, that will help in sodium potassium balance because it does sodium reabsorption. Aldosterone does sodium reabsorption, okay? And it does potassium secretion. So it retains the sodium, kicks out or removes the potassium. Increased sodium in blood leads to increase in blood pressure, because whenever the sodium concentration will increase in the blood, water has affinity for sodium, water will also increase, water will be reabsorbed, water will be retained. So water is retained means blood volume is increasing. Blood volume is increasing means more pressure required to push the volume, large volume of blood. So that is why blood pressure will increase. So question for you, when sodium concentration increases, what does happen to the blood pressure? Does it increase or does it decrease? It increases. When when more water is reabsorbed, because more salt content is there, blood pressure increases or decreases? Blood pressure is increasing because the volume is increasing. We need more pressure to push the blood volume. When potassium levels are high, aldosterone is secreted to lower potassium levels. So what aldosterone will do, it will kick out the potassium through secretion and retain the sodium through reabsorption. ANP, that is made by the right atrium of the heart. It causes the sodium to be eliminated in the urine. If sodium is removed, water will also be removed. So ANP causes more urination, more water will go out. And if more water will go out, that means decrease in the blood pressure. It is antagonistic in function. It will bring the blood pressure down by kicking out the sodium, kicking out the water. Parathyroid, that's made by parathyroid gland. It causes more calcium to be reabsorbed. It increases the blood calcium levels and secreted when calcium levels are low. So kidney does have a role in calcium. Hormones acting on DCT and collecting ducts, that is, they increase the blood pressure. Who are they? ADH, we just talked about it, how it increases the blood pressure, okay? Because it's going to attach aquaporins to the collecting duct and retain the water. If you retain the water, that means blood volume increases, that means blood pressure will increase. And aldosterone, that will increase the sodium retention and increase the blood pressure. Hormone that decreases the blood pressure is ANP, because this guy will kick out the sodium and it will kick out the excess water. And parathyroid controls calcium. Erythropoietin, red bone marrow, increases RBC. Calcitriol, the conversion of calcidiol into triol by the kidneys. And then renin, that is whenever the blood pressure drops, renin acts. I already explained to you through angiotensinogen converting into angiotensin 1, 2, and then how it increases the blood pressure. JGA, that is consisting of the macula densa that secretes the renin, and it helps to increase the monitor and increase the blood pressure. Then angiotensin 2, this causes vasoconstriction, formation of ADH, aldosterone, and feeling of thirst. All of these changes we have already discussed when we talked about renin. This is a table showing the functions, specific functions, and the mechanism. We have discussed all of it. Right here, diagrammatically, it shows step 1, 2, and 3. This is from your textbook, so you have access to it. And at each step, what happens? Urine flow, urine is fine-tuned in distal convolutor. To fine-tune means finally we have the least amount of water being lost. Maximum is retained and reabsorbed back. Then urine moves through by peristalsis movement, and they prohibit reflux because it moves through the slit that acts like a functional valve. Bladder, it accumulates urine, and we have stretch receptors in the bladder that will send the impulses to the sacral spinal nerve. So you get the feeling, the sensation, it travels to the brain, and then the parasympathetic will stimulate the muscle wall of the bladder. We talked about detrusor muscle. Detrusors are thrust down so that the sphincter will open, and once the sphincter relaxes, urine will flow out. We have an internal urethral sphincter that is involuntary, parasympathetic. The external one is voluntary, sympathetic. Micturition is the process of urination, okay? And the skeletal muscles that are involved in the external urethral sphincter that gives us the voluntary control when to go to the restroom. Urethra, we have a short urethra, female, and urethra is angled forward, okay? That helps in continence, and it will not allow the urine to leak. Whereas in case of older women, this angle is lost, it becomes more straight, and that is why with laughing or sneezing, the urine can leak and it causes continence issues. So in case of male, they have a longer urethra, and since it passes through the prostate gland, if the prostate gland will hypertrophy, a majority of the males, they will constrict the urethra, so they have poor urine flow. Now these are the characteristics of urine. Color, urochrome is the pigment that is urine yellow color due to the breakdown of RBC, the specific gravity, and this will show you a color chart of the urine color and what it means, which one is severely dehydrated. This is how it looks. Osmolarity of urine, odor, solutes that are present, and the crystals and stones that can form if you're not drinking enough water. These are some of the normal crystals, and these are abnormal crystals which end up forming stones. Abnormal components, you should not have glucose in the blood. You should not have amino acids and proteins, in the urine. You should not have glucose, amino acid, and protein in the urine. You should not have RBC in the urine. You should not have any of these in the urine. If they come in the urine, that means they are abnormal. Pus cells will happen. If there is any bacterial infection, then they will show up as pus pyuria. And ketones, we talked about ketones in the previous class. So basically, if the fats are being broken down for a source of energy, you're going to find ketones forming there in the urine. And bacteria should not be there just because of any bacterial infection. Too much of pus cells may be seen in the urine. Anuria, less than 50 ml of urine produced per day. And then oliguria, that is scanty amount of urine. Control of urine formation. So normal glomerular filtration rate, normal is 125. As we grow older, it's going to reduce to 90, 80, 70, 60, and then chronic kidney disease is seen below 16. The greater the blood hydrostatic pressure, the greater the filtration and the dilation of the afferent arteriole and constriction. These two play a major role in the pressure generation, that is the glomerular hydrostatic pressure. We talked about glomerular hydrostatic pressure in one direction, capsular opposing it, and BCOP opposing it. This one. Okay, we talked about this one. Then how does kidney control the blood pressure? We talked about renin and how it works through the renin angiotensin aldosterone system. If you have questions over here, give me a call or text me or email me and I can explain that to you again. How do we control filtration in kidney? By controlling definitely the blood pressure. And we talked about sympathetic nervous system, hormones, renin, autoregulation through the mesangial cells, and the tubuloglomerular feedback. Sympathetic nervous system, fight or flight. The afferent arteriole will constrict to decrease the amount of filtrate and urine production. So you get a question over here. When they constrict, what happens to this one? Does it increase or does it decrease? Autoregulation. If suddenly the blood pressure will rise, the afferent arteriole will constrict to decrease the filtration. So you'll have a question over here. If blood pressure decreases, the afferent will dilate to maintain the filtration. So I have explained all of it. Then control of urine formation. The tubuloglomerular feedback detects a high amount of sodium. So GFR is too fast, the filtration will decrease. What are the urine function tests? You can do a urine function test to look for urea, the creatinine, and potassium, and to check the clearance. So there is a formula to know the clearance. We look at the things that are secreted. It should be secreted. And if the body is becoming acidic, we get rid of H+. If H+ is not getting secreted, that means the body is becoming more acidic and kidney is not functioning. That's why H+ is not getting secreted. Potassium also should be secreted. And if the body has a lot of potassium ions, that means it is going to affect the heart function. That's why typically people who suffer from chronic kidney disease, towards the later days, towards the end point, kidneys are totally gone. Failure. So more potassium. And if there is more potassium, then it's going to cause a heart attack. And high potassium in the blood, that means kidney is not functioning. Potassium are not getting secreted out through the urine. Urine function test. So these are the normal levels. And if it is a high amount of urea nitrogen, that means poor renal function. High level of creatinine, poor renal function. Clearance. This is the formula for calculating the clearance, concentration of substance in urine multiplied by volume of urine, and this is divided by concentration of substance in plasma. Glucose clearance should be 0. And increase the clearance, the kidney is removing the substance from the bloodstream and into the lumen of the tubule. That means increasing the clearance. It's not showing up in the urine. Then kidney removes hydrogen ions by secreting into the urine. We know that. Tubular cells have carbonic anhydrase enzyme. So this is how bicarbonate is formed, okay? And H+ is exchanged for sodium as an antipotor. I told you antipotor means moves in opposite direction. Sympotor means same direction. So sodium is taken back into the system. Hydrogen is thrown out into the urine. This is reabsorbed. Sodium is reabsorbed. Hydrogen is secreted. Bicarbonate, we need it in the body because it acts as a good buffer. So that is reabsorbed. And H+ ion secretion depends on the pH of the blood. So if the pH, normal pH is 5 and 6, so based on the diet, if you are having too much of acidic content inside, more H+ will be secreted. Ammonia can buffer H+ ions in urine and it creates ammonium ions. So ammonia acts as a good buffer by taking up the H+ ions and getting rid of it as ammonia. So kidneys can regulate H+ secretion by controlling the acidity of the urine. So if the urine report says that it's a very, very acidic urine, very high acidic urine, more than the normal level, that means you are producing more H+. That means you are having a more acidic diet. Lungs can regulate H+ rapidly through breathing. So here's a video. And finally, uremia, there's a retention of waste products in the blood. If the kidneys are failing, if the kidneys are not able to function as well as they should, they are retaining urea, and that condition is called uremia. So that finishes off our close to 152 slides of urinary system. So I hope you understood the anatomy part, the structure, the physiology, the mechanism, the function, filtration, reabsorption, secretion, cortical nephrons, medullary nephrons, and the arteries that are involved that bring the blood, and the veins that take back the blood. We discussed about the pressure that works at the glomerulus for the filtration, the glomerular hydrostatic pressure versus the capsular hydrostatic pressure acting in the opposite direction, and also the BCOP, the blood colloid osmotic pressure, also acting in the opposite direction. So the net filtration was 10 millimeter mercury pressure. So we talked about the glomerular filtration pressure. We talked about PCT and the limb going down, the descending and the ascending one. So the descending one is freely permeable to water, but for the ascending one, we need to depend on ADH, and ADH will help in fixing aquaporins as gateways, so water can leak out through that. Why do we want to leak out the water? Because we want to reabsorb the water, retain the water. We don't want a dilute urine. A dilute urine is going to make us dehydrated. And if more water gets away, okay, then the blood pressure will fall. And once the blood pressure falls, it will have other effects in the body. Now, we talked also about the hormones that play an important role. We talked about renin, how it converts angiotensinogen into angiotensin 1, and then converts angiotensin 1 inactive into angiotensin 2 active in the lungs with the help of the ACE enzyme, angiotensin converting enzyme. Now, with the help of this enzyme, it converts in angiotensin 2, that goes and acts on adrenal gland, producing the aldosterone hormone. Aldosterone helps in sodium retention or sodium reabsorption. When you retain sodium, you draw more water in. So the blood volume increases. So naturally, the blood pressure increases. That is one effect of renin. But it does vasoconstriction to the sympathetic division and increases the blood pressure. It also acts on the ADH. So there are different ways how renin helps. The ADH is another hormone, antidiuretic hormone, and that what it will do is it will increase aquaporin to the limb of the loop of Henle, now to the ascending limb. And when there are aquaporins there, water which was impermeable in that limb, now water can freely get out and get reabsorbed back into the system. That's why ADH is very important. Heart produces ANP, atrial natriuretic peptide. And this guy will just work in reverse. It will allow more fluid to get away. Okay, it will allow more fluid to get away, and it is antagonistic in function opposite. And so more fluid goes away, then the blood pressure inside will fall. But this mechanism is used to maintain homeostasis. Suppose the blood pressure is too high, this will help in, ANP will help in bringing the blood pressure down. So renin, ADH, ANP, and then there are others like parathyroid hormone, vitamin D, which is converted in the kidney, and how it helps in calcium metabolism. So kidneys also involved in erythropoietin secretion that will act on the bone marrow to increase the RBC production. So a person who has kidney disease may produce less erythropoietin, may show more potassium in the blood. Potassium is not getting secreted. So that means potassium is going to act on the heart and cause heart failure. So kidneys not only do production of urine, but they have wide other functionalities as well. So I discussed the structure of the kidneys, the function, the physiology, the mechanism, the pressure. I hope you are like reading it all thoroughly, going over the slides and trying to understand the lecture. If you have any questions, ask me, or you can email me later on. Any questions?